Many times parents bring their children because they suspect that the child has taken something caustic substance, and they come to you essentially to seek reassurance because the child is asymptomatic or mildly symptomatic and quite active. But that is what we find very difficult to give, because these caustic ingestion can sometimes lead on to inflammations of the esophagus and stricture formation later on, even in asymptomatic children. Today's topic of discussion is when should we be insisting on an endoscopy in such children who have suspected to have ingested a caustic substance. Now, when we see a patient with caustic ingestion, you might see them in shock. You might see them with severe burns all over the body, including the mouth. Now, whether we are not discussing such a case today, nor are we discussing a case in which the history of ingestion is sure to be not to be a caustic ingestion. For we are sure it's not a caustic ingestion, that's not the point of discussion today. Now, what we are discussing today is a suspected or a definite caustic ingestion case where the patient is asymptomatic or with mild to moderate symptoms. And in this patient, whether endoscopy is required or not. That is the point of discussion today. Now, the central concern of us in the management is to prevent stricture of the esophagus especially, which is a primary complication of caustic injury. If you don't act at the proper time and the patient develops a stricture, the patient is likely to suffer for the rest of his life. And the endoscopy has to be performed ideally around 24 hours to evaluate the extent of injury, predict prognosis, and guide the management. The management would involve maybe in some patients just observation if it is not very bad. In others, it might involve giving steroids. In others, it might involve dilatation. Therefore, endoscopy is crucial to be performed at the right time. And the usual time is between 6 hours to 4 days. Now, if you do it before 6 hours, the full extent of the injury may not be clear, and after 4 days, the risk of perforation increases. Therefore, to complicate all these matters is the fact that even asymptomatic patients can have burns severe enough to produce strictures. This is, in other words, the presence or absence of any clinical feature does not reliably predict ingestion or the presence or severity of esophageal or gastric burns. Therefore, even in asymptomatic patient, we have to act at times. Therefore, we have a very critical decision to make, and that is why we are dwelling deep into this real issue. Now let's go into the theoretical aspects of caustic ingestion. A substance is a caustic if it is capable of burning or corroding organic tissue by chemical action, typically due to strong acid or alkaline properties. That's the definition of a caustic substance. The common caustic agents are of household cleaning products, including household bleach or oven or drain cleaners, which are strong dyes that contain sodium and potassium hydroxide. By the strong dyes, you mean alkaline substances. Other common cleaning agents include laundry, dishwasher detergents, and cleaning agents with sodium phosphate and sodium bicarbonate. Now, alkaline agents are more commonly ingested compared with acidic agents, which are bitter. You and I know that if you put an acid in your mouth, it's immediately bitter. Therefore, it's unlikely the child will drink more of acids, but alkalines are less bitter. Now, alkaline agents tend to cause esophageal injuries. The pH is above 11.5 to 12.5 via liquefaction necrosis. Now, this pH is worth remembering because sometimes the patients do bring the liquid which the child has swallowed, and very rarely it might show the pH of the liquid. And acids tend to cause when the pH is less than 2 by a coagulation necrosis. Esophageal injury from acids may be attenuated may become less severe compared with alkalis and perforation of the esophagus is less common. Or in other words, alkali is more dangerous because acids you tend to take less and it tend to be less chances of causing perforation and stricture. Standard liquid household detergents, phosphate and bleaches have a pH ranging from 9 to 11 and rarely cause serious injuries unless taken in large amounts. Therefore, this is the commonest thing which children normally come with ingestion, and rarely they cause serious injuries. But we can't take this for granted. At the same time, the concentrated forms of laundry or dishwasher detergent, especially single-use packet like capsules, gel packs or pods, are increasingly available and much more likely to cause esophageal injury. Household bleaches are relatively common ingestion but rarely causes esophageal burns. They are typically composed of about 5% sodium hypochlorite and have a pH of approximately 11, which is below the pH threshold of 11.5 to 12.5, and tend to cause esophageal injury. When burns do occur with these agents, they tend to be mild and usually do not require treatment. Cosmetic products such as hair relaxers are ingested commonly, but they appear to be rare causes of esophageal injury. Wart or callus removers contain salicylic acid and has caused esophageal injury in case reports. The colloid suspension is viscous, which likely contributes to the injury by prolonged contact with the mucosa. Common acid household products include toilet bowl cleaners, battery fluids, and hydrochloric acid solutions used in swimming pools. Now remember this, children living on farms may be at particular high risk of incurring serious burns because they contain products which are of industrial strength and more commonly used in this setting, and they are more concentrated. Therefore, these theoretical knowledge may be of help but may not be of help in taking a final decision. But you can keep it in the background when you take a decision. So some of these things are, some of the theoretical important things are, alkali is more toxic than acids. And you must remember that if the pH of the solution is between 2 and 11, probably it is not very problematic. And of course, children who are coming from living in farms and have consumed something which are used in farms are more likely to have corrosive burns. And drain cleaners are more dangerous than household detergents. Just a passing remark. Sometimes a patient who has taken a caustic injection which the mother has not noticed may come to you as totally collapsed, and you might think that this is an anaphylaxis. There are case reports, and I myself have seen 1 or 2 cases like this. Now we come to the practice. Now if you are looking for an international guideline which you can rely on for the management, for the indication for endoscopy in a suspected case of caustic ingestion, I didn't find any. Well, if you are looking for international guidelines, I said it's difficult to find one. But the closest I came to is an article which came about in the New England Journal of Medicine as late as April 2020. I made an algorithm of their suggestions. Now, if you have a suspected caustic ingestion, and if it is an acid, you straight away go in for endoscopy. It's a little surprising because I thought that acidic ingestion, it is well known that acidic ingestion are less dangerous than the alkaline. Both are dangerous, of course, both are caustic substances. But here it says all acidic ingestions, you have to do an endoscopy. When it comes to alkaline ingestions, they divide it into intentional and unintentional. And you know, in intentional poisoning, it is always more dangerous. We know that intentional poisoning is more common in adolescents and adults rather than children. And children, it is usually unintentional. That is why poisoning in children are less likely to lead on to mortality. But if you have an alkali ingestion which is intentional, then again you have to do an endoscopy. Therefore, summarizing, all acidic caustic injection suspected, even suspected, or an intentional alkali injection, you go in for an endoscopy. Now, if it is unintentional and the child is asymptomatic, absolutely no symptoms, then you can probably observe him for 4 to 6 hours. And if he remains asymptomatic, you can discharge him after 4 to 6 hours. Now, the problem arises in unintentional when he has symptoms. If he has any one of these following symptoms, that is vomiting, drooling, or inability to take food orally, these are the 3 symptoms which they normally have. What you do is you observe him overnight, you give a trial of clear liquids and then food as tolerated, and you do an endoscopy if the patient is unable to drink. Therefore, is any one of the symptoms, still you can give in for observation. Now, here is what this article has splits the symptom. Instead of one of the symptoms, if the child has both vomiting and drooling, or stridor alone, then the patient goes in for endoscopy. Therefore, here there is a small difference, that there is a hair splitting of the symptoms. Only vomiting with unintentional alkali ingestion or only drooling, you need not do an endoscopy. But if you have both vomiting and drooling or stridor, you have to do an endoscopy. Therefore, this is a I like this. I mean, this is an article which came as late in April 2020 in a respected journal. But the problem here is you have to know whether it is an alkali or an acid with the child ingested. Therefore, in summary, all acidic and intentional caustic ingestion suspected, you have to go in for endoscopy. And if he is symptomatic and he is having both vomit, even if it is unintentional and alkaline, if he has 2 symptoms, vomiting and drooling or stridor alone, you do an endoscopy. Others, unintentional, asymptomatic, or only one of the symptoms, probably you can give them a trial of observation. Now, these are based on a landmark study by Crane and colleagues that only children with vomiting and drooling or stridor alone have clinically significant injuries. Therefore, the children who had no symptoms or with only vomiting or drooling had no more than grade 1 injury. It's a very significant point because if they have only vomiting or drooling, previously people used to do, even with children with drooling, they used to do endoscopy. They can escape this invasive procedure. Mind you, when you want to do an endoscopy in a child, you have to give general anesthesia, you have to find a pediatric gastroenterologist, or you will have to find a pediatric surgeon who is happy to do it, and to go to a center where there are endoscopes available. In contrast, half the children with both vomiting and drooling or with stridor alone had grade 2 or more severe injuries which required intervention. Now, the other guideline which I see is of course from UpToDate. It looks more practical to me. So therefore, when you have a suspected caustic ingestion, it says it doesn't divide into acid or alkali. It looks whether the ingestion is definite, the symptoms are severe, and then it requires airway evaluation and endoscopy under GA within 24 hours. That's not the point of our concern today. Now, if at the same time the ingestion is definite, but the symptoms are none to moderate, note this down, even if there are no symptoms, oral burns are present or absent, you consider airway evaluation and straight away do an endoscopy within 24 hours. Therefore, note this point here that even if there is no symptom, if the child has definitely ingested something, therefore this UpToDate doesn't say whether it's alkali or acid, you go in for an endoscopy. I think this is more practical from the practical point of view. And if it is of questionable, now the third point is if it is questionable, or it is an ingestion of household bleach which you are definitely knowing that it is not problematic, and there are no symptoms, and there are no oral burns. Then you offer clear fluids observation for 2 to 4 hours. And you can discharge if the patient is asymptomatic. Therefore, in definite ingestion, you go ahead with a caustic substance, whether it's acid or alkali, you do with an endoscopy within 24 hours. But if it is a substance questionable, you are not sure whether the child has taken anything, or you are sure he has drank a household bleach, and there are no symptoms and no oral burns, you can discharge after 2 to 4 hours of observation. And if we develop symptoms, you can do an endoscopy. If you go back into this, because looks to me more practical than the other one, because you don't have to know whether it's acid or alkali. But probably you will be doing more endoscopies than if you follow the New England Journal algorithm, where you can escape an unintentional alkali ingestion if the child has no symptoms or only drooling or difficulty in swallowing. He may not require an endoscopy. Here it is something more. All definite ingestions of caustic substances, even asymptomatic, you have to do an endoscopy within 24 hours. Now, nothing is complete in a pediatric discussion without stating what is given in the Nelson's Textbook of Pediatrics. In the 21st edition of the Nelson's Textbook, it says upper endoscopy is recommended in all symptomatic patients in the chapter shown above. But however, in chapter 12, in another chapter, it says endoscopy can be performed within 12 to 24 hours of ingestion for prognostic and diagnostic purposes in symptomatic patients, or those with suspected injury on the basis of history and known characteristics of the ingested product. It doesn't go into the detail, but probably goes along with the what the up-to-date elaborates in a better way. But it surprisingly adds that an endoscope role is purely diagnostic and states whether the risk of the procedure is justified is debatable. I didn't understand this, but this is what is written in our textbook of Nelson's textbook. But moreover, it agrees that all symptomatic patients you have to do it, and it says that in asymptomatic patients we have to go by the basis of history and known characteristics of the ingested product, which is what the guideline given by UpToDate also state. Now I have to tell you something. After I have discussed so far the indication for endoscopy in a caustic injection, where you have to take a very critical decision. The timing is important. To say no is difficult. There's a big controversy behind this. The Lancet article in May 2017 came about statement that CT examination is reliable and reproducible in assessing transmural digestive necrosis and improves selection of patients for surgery. In other words, it prefers CT over endoscopy. The major drawback of endoscopy is its inability to predict accurately the depth of necrosis and selection of patients for surgery. And it goes on to state that endoscopy is observer dependent. And to add credence to this, in 2015, the World Society of Emergency Surgery Consensus Conference supported the introduction of emergency CT in the management of corrosive ingestion. Therefore, there are people who say that CT scan is better because it gives you the depth of necrosis, and it also identifies, and the selection for patients for surgery is better done by CT. You don't have to do an endoscopy at all. But you remember that this article in the New England Journal is in 2020, and this article is in 2017. And the same authors have questioned what is given in the New England Journal, and they have said that CT is the one which should be preferred, countered it by letter to the editor, and endoscopy should not be the first line of investigation. But however, the editor, as well as the author of the article in New England Journal, has come about refuting this and telling that endoscopy is better, and it also selects patients who requires steroid treatment. Not only patients require surgery, but it requires, some children are requiring high dose steroid treatment also to prevent uh, stricture formation. Therefore, that's a debatable issue. I cannot go into depth in this matter. Rather than mentioning this, in conclusion, I would like to say that this is not a trivial decision. This is a difficult decision for the pediatrician because it is not easy to push for an invasive procedure like endoscopy in an asymptomatic or mildly symptomatic child with unknown suspected caustic ingestion. In any situation, now, therefore, what happens is, to complicate the matter, sometimes the opinion of the gastroenterologist or the pediatric surgeon may be different. And I feel if there is an indication for endoscopy, it is a pediatrician's responsibility to counsel the patient for endoscopy and explain to him the reasons behind that and refer him to a center where it's available. Therefore, it becomes a tricky matter. And on the first of all, in most cases, in 9 out of 10 or 1 out of 50 only, you may find a significant finding. Therefore, even in asymptomatic or mildly symptomatic cases, at the end of the day, the endoscopy is likely to be normal. And you may not come out in, as far as the patient is concerned, with flying colors. But you still have to go through this, because if you have ever seen a child with stricture after a caustic injection, you will never forget it for the rest of your life. Now, how do you tackle this rather difficult situation? Each one of you will have your own methods. But I go about counseling the parents afront regarding the need for endoscopy and the rationale behind that before I refer to the pediatric surgeon or the gastroenterologist. On the referral letter, I document that I have already counseled the parents the need for endoscopy, and I even talk to them and to them to tell them why exactly I am asking for an endoscopy. Now, most of them do agree, but sometimes the opinion of the gastroenterologist and pediatric surgeon is in variance with your opinion. But I still then insist on an endoscopy and refer him to a place where he can undergo the procedure. Therefore, we have come to the end of the presentations, and I am Dr. A. Padmanabhan, and I blog on the site pediatrictheoryandpractice.wordpresses.com. Normally, this is a clinical decision aid, and I give evidence-based, up-to-date information, so that this is mainly aimed at general pediatricians as well as general practitioners who cannot escape from making these difficult decisions in primary and secondary care. I dissect only one clinically relevant bedside issue at a time, and I hope this has been useful to you, and I would like to hear from you. You can write your comments on the bottom of the blog. Thank you.